a seminar from Berkeley.
Good afternoon, sir. Good afternoon, ma'am. Good afternoon, sir. My name is Dr. Dubdesh Laputia. I'm an MBBS intern. I'm going to present a seminar on valproate. So, valproate is a simple branch in carboxylic acid, and the commercial formula derivatives include valproic acid, valproic sodium injections, and divalproate enteric-coated delayed release complex and in tablet formulation. Pharmacokinetics. All formulations of valproate are rapidly absorbed. Its oral absorption is highly effective, and peak plasma concentration is obtained 3 to 4 hours after intake, oral administration. The half-life of valproate is 10 to 16 hours, and when used in combination with other psychotropic agents, valproate has valproate have higher degree of plasma protein binding, such that it displaces the agents and increases their P levels. It is completely metabolized by liver through hepatic glucuronidation and mitochondrial beta oxidation and excreted through urine. Mechanism of action. Like phenytoin and carbamazepine, it prolongs the recovery of voltage-gated sodium channels, and it increases the level of GABA, and as it stimulates the activity of GABA synthetic enzyme and inhibits GABA degradative enzyme. So it is effective in mania. It also blocks NMDA glutamate receptors, so useful in bipolar disorders, and reduction of type 2 calcium currents in thalamus. Indications of valproate. It is best known as broad-spectrum anticonvulsant, effective in all kinds of seizures, like myoclonic seizure, GTCS, atypical absence, complex partial seizure, atonic seizure, chronic and clonic epilepsy. Valproate is also found to be effective in treatment of acute mania and in those patients who have failed to respond to lithium or could not tolerate lithium. It is also found to be effective in bipolar depression. And the National Institute of Health and Clinical Excellence, NICE, recommends valproate as first line of option for treatment of acute episodes of mania in combination with antidepressant. for treatment of acute episodes, but importantly, not in women of childbearing potential, but it is human teratogenic that may cause impaired cognitive function in children exposed to valproate. In outpatient setting, when prescribing uh, valproate, one should obtain a baseline hepatic panel and complete blood profile before prescribing the and drug interactions of valproate. It is highly protein bound and can be displaced by other protein bound drugs such as aspirin. So aspirin leading to toxicity of valproate. Aspirin also inhibits the metabolism of valproate, and a dose of at least 300 milligram of aspirin is required to do that. Less strongly protein-bound drugs such as warfarin can be displaced by valproate, leading to higher free levels and their toxicity. Valproate is hepatically metabolized, so the drugs that inhibit CYP enzymes can increase valproate level. For example, fluoxetine, erythromycin. Valproate can increase the plasma levels of some drugs by inhibition of glucuronidation. For example, tricyclic antidepressants, particularly clomipramine, lamotrigine, quetiapine, warfarin, and phenobarbital. Valproate also significantly lower plasma olanzapine concentration. The mechanism is unknown. The anticonvulsant effect of valproate is antagonized by drugs that lower the seizure thresholds, for example, antipsychotic. Weight gain can be exacerbated by other drugs such as clozapine and olanzapine. And well, so this is a table from Maudsley. It is showing valproate prescribing and monitoring criteria. Indication of valproates, as we have seen earlier, mania, hypomania, bipolar depression, and prophylaxis of bipolar affective disorder. And pre-valproate workup, we should obtain a complete blood profile and LFT of a patient, and baseline measure of weight is also required. Prescribing this drug, that we can titrate the dose upwards by seeing the response and side effects both. And according to that, we can titrate the dose upwards. And the constant release sodium valproate can be given once daily. All other formulations must be administered at least twice daily. Monitoring of valproate can be done by complete blood count and LFT and weight, or we can see BMI also. And to stop this drug, reduce slowly over at least 1 month. Adverse effects of valproate, it can cause both gastric irritation and hyperammonemia, both of which can lead to nausea. Lethargy and confusion can occasionally occur at starting dose above 70 milligram per day. Valproate causes dose-related tremor in up to a quarter of the hair loss and curly overgrowth and peripheral edema can occur. Other side effects are thrombocytopenia, leukopenia, red cell hypoplasia, and pancreatitis. Valproate can cause hyperandrogenism in women and has been linked with development of polycystic ovaries. Valproate can also cause fulminant hepatitis, and young children receiving multiple anti-seizure medications are mostly at risk. Many side effects of valproate are dose-related, and an increase in frequency and severity when plasma level are more than 100 milligrams. Valproate monotherapy, uses of valproate in pregnancy. Valproate is not safe in pregnancy because valproate monotherapy can also be have also been associated with an increased relative risk of atrial septal defects, cleft palate, hypospadiasis, polydactyly, and craniosynostosis. Although absolute risks are low, valproate is also associated with reduced head circumference in neonate. There appears to be clear causal association between valproate in use in pregnancy and motor and neurodevelopmental problems in exposed children. Poorer outcomes have been shown in language functioning, attention, memory, adaptive behavior compared with carbamazepine and lamotrigine exposure. Lower IQs and increased diagnosis rate of autistic spectrum disorder are also reported. Processing, working memory, and learning deficits appear to be dose-related. Valproate use may increase risk of pre-eclampsia. NICE advises against the use of valproate in pregnancy. Valproate should be discontinued before a woman gets pregnant or becomes pregnant. Women taking valproate who are planning a pregnancy should be advised to gradually stop the drug because of high risk of fetal malformation and adverse neurodevelopmental outcomes after any exposure in pregnancy. Also, if valproate is the only drug in woman which is working for her, then she should be explained all the outcomes and side effects and risk of this drug, and a consent form should be signed confirming that she understands the risk of malformation and developmental delays. Uses in lactation. Valproate is risky drug in pregnancy, but a relatively safer drug in lactation. And acute adverse effects in infants are all reversible, and they are thrombocytopenia and anemia, which can be reversed after stopping of breastfeeding. And thank you.
I think we'll take questions. Not it. तुम्हारा ये ठीक है क्वेश्चन नहीं लेते yes हमारे point है any comments from residents? That's good. What presentation for interest references बताए तुमने ठीक So, what is the difference of evaluating teaching level? How is the difference of what is the difference when you last when on which day you same dose just before the next dose. Okay, so अगर नीचे आपकी डोज चल रही है तो सुबह भेजना है और the next dose रात को देगी बिल्कुल अगर मतलब 1 से 10 डोज चल रही है for some reason तो अगले रात को डोज से पहले उसका ब्लड देगी पूरी डोज अगर जा रही है तो करते ठीक नेक्स्ट इज डॉक्टर अभिजीत तो पहले भेज दो लाइट डोज पहले दे दो मान लो डोज और अगर आप सेम डोज है तो कभी ठीक है रात को पहले ब्लड ले लो भेजा है ना ब्लड का दे या कभी इमीडिएटली ना होता और या सुबह डोज है मान लो कि अगर डोज है आपकी ऑल्टर सुबह 300 है 500 तो क्या करो कभी इतना सिग्निफिकेंट नहीं है बट है तो जो कम डोज होगी ना उससे पहले भी कर सी प्रॉपर या श्योर हमें बॉडी में मिनिमम लेवल हमें पता है कि मिनिमम कंसंट्रेशन वो काम करना है तो इसलिए कम लेवल तब होगा जब हम डोज को इससे ज्यादा डोज जब देनी है ना उससे पहले चेक करना है ठीक है अगर मेरे सुबह 5 मिनट आपका 5 मिनट डोज से पहले चेक ठीक है क्योंकि जब लेवल कम होने की चांस है ना मिनिमम लेवल पर आएंगे ना बट ये तो सिर्फ बट इट्स टॉप लेवल नेक्स्ट डोज करें 5 मिनट अपने शाम को दिया या रात को तो सुबह also like lithium has a very narrow therapeutic index
We are also concerned about toxicity. Ultimately, we are like toxicity to a concern, but minimum level whether it is not there or not. That is what it is. Right.
Is that आपका लेवल सेट करने का पर्पस भी फुलफिल होता है तो उसके हाफ लाइफ कम है तो इंटरनेट केस में आप ब्रीड ऑफ करनी ब्रीड ऑफ में अपना लेवल मतलब एक अगर आपको कोई ऐसा कंपोनेंट है और जो अभी के बहुत ही मतलब क्लियर नहीं कौन सा ऐसा इसका फॉर्मुलेशन है जिसका अलग डोज मिलते और 24 डोज मिलते हैं मान लो कि आप बिलीव करके एल्फरेट करना सकते हैं दोनों कंपोनेंट और दोनों कंपोनेंट है मतलब कोई कंपनी देखते हैं तो अगर आप वो पॉलीगोनिक ले थोड़ा कंप्लीट तो आप अपने दोस्त सिंगल डोज से करेंगे लेकिन इमीडिएट डोज में अगर आप लेवल चेक करते हो तो योर पर्पस इज नॉट सॉल्व इमीडिएट डोज यानी आपने मैसेज को हमें पता है कि वो 24 आवर मेंटेन करेगा तो हमारा पर्पस ही खराब हो जाएगा इमीडिएट डोज में प्लीज कैलकुलेट अगर हम सिंगल डोज कर रहे हैं तो इन दोनों तो सिंगल आ जाएगा मतलब
Okay, so next presentation is by Dr. Abhijit. He is going to talk on naltrexone and naloxone. These are the two medications that are available with us.
Thank you, sir. A very good afternoon, everyone. Today I'll be talking about naltrexone and naloxone. My moderator is Dr. Mohan, sir. So in this presentation, we will be talking about, first we'll be talking about the opioid receptors. Then brief we'll talk about naloxone and then naltrexone. So first we'll start with opioids. So what are opioids? Opioids are a group of psychoactive substances that are similar in action to that of opium poppy. So basically the opioids are extracted from the plant Papaver somniferum. And we can classify opioids on two bases. First is the source, and second on the basis of its receptor, on what receptor does it work. So I have only put mostly the opioids which we use in our which we are seeing in our day-to-day life in the department. So if it start with natural derivatives, it is morphine and codeine. With semi-synthetic derivatives is buprenorphine and heroin, and synthetic are methadone, propoxyphene, and pentazocine. And if we talk about the second classification of the opioid, which is based on the receptor, so opioid receptors are G protein coupled receptors, and they mediate the human body response to hormones, neurotransmitters, and drugs. So mostly if we talk about opioid receptors, there are mainly three receptors which are related to opioid functioning. So they are mu receptors, kappa receptors, and delta. They are if we talk about subclassification, there are total 17 opioid receptors. They are so mu receptor is further divided into mu1, mu2, and mu3. Kappa receptors are divided into kappa 1, kappa 2, kappa 3, delta and delta 1, delta 2, zeta receptor, and nociceptin receptors. So if we talk about the functioning of these receptors, mu1 receptor is basically involved in analgesia and the dependence, whereas mu2, this is one of the most important receptor because any overdose of opioid is mediated through this receptor only, where we see any pinpoint pupil or any respiratory depression is because of this functioning of this mu2 receptor, whereas there is mu3 receptor, which causes vasodilation. Then there's kappa receptors, which causes analgesia, diuresis, and dysphoria. Dysphoria is any uneasiness, we call it a dysphoria. And delta receptor is responsible for analgesia and reduction in gastric mortality, whereas zeta receptor is responsible for regulation of regulate developmental events in a variety of normal and tumorigenic tissue and cells, whereas nociceptin receptor is responsible for analgesia and hyperalgesia. So hyperalgesia is the term which is used for increased sensitivity to the pain. So this is the classification of opioids. So opioid can be further classified in strong agonists. Strong agonists here, if we talk about our the drugs which we used here are methadone, and then if we talk about mild to moderate agonist, there's codeine, which we use normally. Then there's mixed receptor action, in which we see buprenorphine, and there's miscellaneous, which is tramadol, and opioid antagonist, which we are going to talk about here. They are naltrexone and naloxone. So this is a small chart which shows us how this different opioids they work on the receptors. So this methadone, if we talk about methadone, if we see here, it's a strong agonist. So what it does, it has an agonist action on the mu receptors. So mu receptors, they are mu1, mu2, mu3. So they are mostly responsible for finite dependence, and they are responsible if there is an overdose, it will cause an pinpoint people, or it will cause any respiratory depression. Whereas a buprenorphine is a, if you see a buprenorphine, it has a mixed receptor action. So it is a partial agonist which works in mu receptor, kappa opioid receptor, and delta opioid receptor. And if we are talking about naltrexone is a antagonist which antagonizes mu receptor. And whereas in nalmefene is also an opioid antagonist which works on the mu receptor. It is an antagonist. So if here we are starting with our main topic, that is naloxone. I'm talking about naloxone because naloxone was introduced before naltrexone. So we'll start with naloxone. So naloxone is a medication which is approved by the FDA, it is designed to rapidly reverse opioid overdose. So naloxone is an emergency drug, we can say, because it is used in any opioid overdose condition. So it's an opioid antagonist, meaning that it binds to the opioid receptors and can reverse and block the effect of other opioids, such as heroin, morphine, and oxycodone. Administered when a patient is showing signs of opioid overdose, naloxone is a temporary treatment, and the effects do not last long. So mostly the half-life of naloxone is roughly around 30 to 90 minutes. So it's a very short-term drug. So this naloxone is not orally effective. It can only be given by through intranasal. Narcan is a very famous formulation, though we don't use it in India, but it is an intranasal spray Narcan, which is used in foreign countries where if we see any patient who's unconscious, or even if we suspect if any opioid overdose is there, we have to take it the Narcan. We have to give him 2 sprays of Narcan, and we can see if the patient is responding or not. It is available in intramuscular, subcutaneous, or intravenous injections. So we talk about the history. The naloxone was first developed in 1960 as a novel opioid antagonist with clear side effect with Dennis precursor. Naloxone hydrochloride is a competitive mu. So basically this naloxone, this works in a mu opioid receptors. I already told you. It is approved for administration. It is available in IIB, IM, subcutaneous, and intranasal route. And it can also be given by inhalation. Like there's a method called ultra rapid method, which is used in the patient where we suspect any overdose is there. So we give the patient anesthesia. We put the patient in anesthesia, and then we use this drug for the patient who are in opioid overdose. So the mechanism of action, naloxone has stronger effect. So if you talk about here, it has a competitive action with the opioid. So it competitively inhibits the receptors. It not only just inhibits it, it also just removes the opioids which are already activated the neurons of neurons. So how can a Narcan save a opioid overdose? Narcan binds, if we talk about Narcan is an intranasal spray. It binds to the opioid receptors. It has a higher affinity than for the receptors. It displaces opioid for a short time. This allows the person to breathe because it antagonizes the mu receptor, which is responsible for respiratory depression. Dosage. So basically we start naloxone initial dosage, we start with 0.4 to 2 grams, and we can repeat this again. We can repeat this dose until we achieve till a dose of 10 milligram is achieved. If still the person is unconscious or still he's showing any signs of, there's no signs of improvement, then we can question the diagnosis of opioid overdose. Because if the patient is still not improving or is not showing any signs and symptoms of improvement, then opioid overdose should be questioned. And these are different different routes through which we can do injectables. The brand name of the injectable is generic. It is given in 0.4 gram ml. It can be given IM and subcutaneously. Where there's an auto injector, which is very famous by the name FZO. It can be given to 0.5 milligram IM and subcutaneous. Where I already told about Narcan. Narcan is an intranasal spray. Intranasal atomizer. It is famous by the brand of generic, and it can be given in doses of 1 mg per ml. So if we have to see, or we have to check whether a person had an opioid free period or not. So this naloxone challenge test is a very important. Mostly naloxone challenge test is used in naltrexone. Before we start the naltrexone, we have to check whether the person had an opioid free period or not. So this test can help us in proving whether the patient had one abstinent period for the opioid or not. So a naloxone test may be helpful if there is any question of occult opioid dependence. If signs of opioid withdrawal are still observed following naloxone challenge, treatment with opioid antagonist should not be attempted. The naloxone challenge test can be repeated after 24 hours. So if we can do this test through two methods. First is intravenous and second is subcutaneous. So in intravenous method, we inject 0.2 milligram of naloxone and we observe for 30 seconds for signs and symptoms of withdrawal. If there's no evidence of withdrawal, again we inject 0.6 mg of naloxone and we again observe the patient for additional 20 minutes. Whereas in subcutaneous, we administer 0.8 gram of naloxone, we observe for 20 minutes for signs or symptoms of withdrawal. After IV administration, approximately 60 to 65% of naloxone is excreted through kidney. Though there are not much data available for the effect of naloxone in liver or the effect of naloxone on liver and kidney, but if the patient is suffering from any hepatic function impairments, and we have to give the naloxone in the decreased dose. The duration of reversal of opioid-induced respiratory depression is brief and dependent upon the dose and potency of the opioid given, as well as the amount of naloxone administered. In healthy volunteers, a 0.4 mg IV dose of naloxone reverses the sedation induced by morphine. The dose of the morphine which it can reverse in healthy volunteers, a 0.4 mg IV dose of naloxone reverses the sedation induced by morphine 0.2 to 0.3 mg per kg within 2 minutes of administration. But the subject began to feel the effect of the morphine again after 15 to 30 minutes and returned to pre-naloxone level of sedation within 45 minutes. So this shows that naloxone is a short-acting drug. So if we have to continuously keep giving the drug because the duration of working of this drug is very less. So the therapeutic uses of naloxone is naloxone opioid overdose reversal and suspected case of acute opioid overdose. Second is buprenorphine combined with naloxone, and third is methadone overdose. So buprenorphine combined with naloxone. So this was seen before that the patient they were given buprenorphine, they were allegedly used abuse of buprenorphine through IV dose. So there's a combination we give with naloxone, because naloxone cannot be, if they are taking orally, so naloxone won't be absorbed orally. So there won't be any issue in that. But if they're abusing buprenorphine through IV dose, so naloxone will be absorbed through IV, and this will cause a withdrawal reaction. So here we can use it. Then methadone. Methadone is a strong agonist, opioid agonist, and severe intoxication or overdose of the opioid constitutes a medical emergency. and causes meiosis are pinpoint people. So here also for the reversal of the methadone overdose, we can use naloxone. So we are coming to our second topic, which is naltrexone. So naltrexone, an opioid, it is also an opioid antagonist, and it was introduced after naloxone because naloxone has, or its other antagonists had some disadvantage, like their half-life was very short, and we can say that that like naloxone was not orally absorbed. So naltrexone was later introduced, which was orally also absorbed, and its half-life is also increased. So in 1948, naltrexone was under the original name trade name Trexan was approved for providing blockage of the effect of exogenously administered opioids in helps in detoxification of the opioid addicts. So naltrexone was approved in 1994 for the treatment of alcohol dependence also. So we talk about pharmacokinetics. Naltrexone is rapidly and completely absorbed following an oral administration of 100 mg dose, with peak plasma concentration of 19 to 44 mg per liter being achieved within 1 hour. The oral viability of naltrexone is 60%, with 20% of the drug being bound to plasma protein. Naltrexone has a plasma life of 10.5 hours, so we can see it has a much a longer half-life than naloxone. And naltrexone undergoes first pass metabolism, so the metabolite product of the naltrexone is 6-beta naltrexone. And both the parent drug and the metabolites are excreted primarily by the kidneys. So if we talk about this drug in hepatic and renal impairment, naltrexone appears to have an extrahepatic side of drug metabolism, and its major metabolite undergoes active tubular secretion. So adequate studies of naltrexone in patients with severe hepatic, still this study is in process, but if we see that patient is having any hepatic impairment, then we try to give this drug in a much lower dose. The maximum dose which we can give per day is up to 300 mg per day. So there is another formulation which is called Vivitrol, which is an extended release of this naltrexone, containing 300 mg of naltrexone, which was created using Medisoft drug delivery technology for once a month. So it has to be given every 4 weeks. So if we divide by 30, it almost gives around 38 mg per day. Following administration of this formulation, an initial peak is seen within 2 hours, and then following a second peak is seen 2 to 3 days later, with a slow decline after the 14th day. So if we talk about pharmacodynamics, naltrexone is non-specific opioid antagonist that binds to all 3 opioids. Like I showed in the initial slide, naltrexone, it is an opioid antagonist which binds to all mu, kappa, and delta. Naltrexone has a minimal opioid agonist effect, and its relative opioid antagonist potential is 12 times that of nalorphine and 2 times that of naloxone. So if we talk about the therapeutic indication, so there are first three indication are FDA approved. So first is alcohol use disorder, second is opioid addiction, third is weight loss and obesity, nicotine use disorder, cocaine use disorder, self-harm behavior, eating disorder, and gambling. So first we talk about alcohol use disorder. The efficacy of naltrexone was, so there were different, I have not put in this slide, but there were different drug trials or different case study were done for the use of naltrexone in alcohol, and it has showed that it has been effective in mostly it has been effective in the patient who are such as male drinkers, those who are those who have a positive family history of alcoholism, and those have with antisocial trait or smokers. It has significantly reduced the craving for the alcohol in those patients. And this addition of gabapentin in naltrexone has shown to improve drinking outcomes. So if we add gabapentin to the naltrexone, it has a beneficial effect as it controls the symptoms of insomnia and any withdrawal cravings is present or any mood instability. So this combination of drug has been proved very beneficial for these patients. So second is opioid addiction. So initially this drug was introduced for opioid addiction only because it's a long acting drug and it's a opioid antagonist. So as a opioid antagonist, naltrexone selectively competes with the exogenous opioid for CNS. This blockade lasts for 72 hours after naltrexone administration and prevent patient from achieving sought after reinforcement from opioid use and from receiving physical dependence if prolonged opioid is received. So opioid detoxification protocol in combination with naltrexone. So as a method for rapid detoxification, outpatient protocols have been developed combining naltrexone with clonidine. So clonidine mostly is a alpha 2 agonist which is mostly it's a hypertensive agent. So if this thus we use this combination. So this what is that is clonidine. It looks after the withdrawal symptoms. It helps in management of the withdrawal symptoms with naltrexone. This combined effect allow patient to be completely opioid free for first day of treatment, to have completely detoxification within 48 to 72 hours, and to be able to commence naltrexone maintenance therapy. So the time when we start, there's a gap between when we stop the opioid and we start. So mostly that gap is the it's a very important time, because the craving and the relapse of the patient is mostly seen in that period only. So if we combine the clonidine with it, so what happens that this any withdrawal symptoms if they are seen, it is managed by the clonidine. And there's a very special. I was going through this, so I found that the clonidine it itself has a property of producing endogenous opioid. So if we give clonidine first and then naltrexone, so what happens if there's any release of endogenous opioid by clonidine? So if we give it naltrexone will look after the it can manage the endogenously released opioid also. So there is a vice versa relation. So there's a variant method of naltrexone only called ultra-rapid inpatient detoxification, involves administering naltrexone to opioid-dependent patients who are placed under light sedation or general anesthesia. So it's called inducing mechanical ventilation followed by detoxification using full dose of naltrexone also. So there's another, it is used in weight loss. It is also FDA approved, weight loss and obesity. So a combination of bupropion combined with opioid receptor naltrexone helps in weight loss also. It is labeled as an adjunct to increase physical activity and a reduced calorie diet for chronic weight management in adults who have a body BMI of at least 30 kg per meter square, or who have a BMI at least, if their BMI is less than 27, less than 30, or but at least 27, but they are suffering from other comorbidities like type 2 diabetes mellitus, hyperlipidemia, or hypertension. Then next is cocaine use disorder. So based on the preclinical studies, so here also many case studies have been done, which has showed that this drug is also beneficial in cocaine use in the patient where there's chronic cocaine use. So naltrexone were associated with modestly improved cocaine use outcomes by when combined with relapse prevention therapy. However, trials in patients with cocaine and alcohol dependence found no benefits of naltrexone in reducing just cocaine use. So then the next is nicotine use disorder. So nicotine administration is known to stimulate the release of endogenously opioid and to attenuate the perception of pain via opioid mechanism. So clinically, laboratory studies examining the effect of opioid antagonists, including naloxone and naltrexone, on smoking behavior have been inconclusive, with some studies showing reduction. So still many studies have been going on, though there's no clear-cut conclusion that it helps in reducing, but there have been some benefits. Some benefit have been shown in this thing. Then there is self-injurious behavior. Naltrexone has been proposed as a treatment for self-injurious behavior and for autistic behavior in patients with mental retardation and autism. Clinically significant symptoms reduction has been reported for numerous open case studies and trials with small sample size. Larger studies using more rigorous experimental design have failed to replicate these reports. Hence, naltrexone utility for these symptoms is still not for the here also for the same the case. The studies has still been going on. Those there have been some improvement have been shown, but we can't say that it's a conclusive result for that naltrexone will help 100% in self-injurious behavior. Then there is eating disorder and obesity. So exogenously and endogenously opioid and admit. So if any opioid, if it's given, then it helps it increases the food intake. So if we give any naltrexone, like it's an opioid antagonist, so it will block and decrease the food intake of the body. So in bulimia nervosa, it has shown some effect in reduction of the weight, but there has not been any conclusive evidence about use of naltrexone in anorexia nervosa. Then its effect on liver, while naltrexone has not been shown to hepatotoxic when administered. When we give naltrexone in a much lower dose, then there's not much effect has been seen. But if the patient is suffering from any hepatic impairment, like any acute hepatitis or liver failure or any significant liver disease, so we have to give the naltrexone is a much lower dose, because that it is metabolized. The naltrexone is metabolized by the liver to give it a active metabolite. So its effect on pregnancy. Naltrexone, when administered at dose of 140 times the therapeutic dose in humans, have been shown to decrease pregnancy in rats. And so in human, the case studies have not been done. So what they have done in rats, so they say if we give a therapeutic 140 times some therapeutic dose, then only its effect is there on the pregnancy. Though for it's same for the lactation also. Though lactation, I've read some articles where they show that naltrexone is secreted in milk, but there hasn't been any conclusive evidence for the same, or there any side effect has not been reported yet for the same. So we talk about the doses. The recommended dose for adult is 50. We start with 25 mg, or we can start with 50 mg also. 50 mg per day for alcoholism and narcotic addiction, where the FDA says that treatment should be initiated with initial dose of 25 mg. If no withdrawal signs occur, the patient may be started with 50 after that. Lower initial dose can be considered over a few days for patient at increased risk of adverse effect, with the dose increase and as tolerated. So mostly we give, here we recommend the patient to have a morning dose, and the injectable formulation of Vivitrol, which is a long acting, which we give once in a month, is available in single kit that contains 380 mg of Vivitrol. Then precaution which we should see before starting on naltrexone are patient currently dependent on opioid, including those currently maintained on opioid or partial. So we have to see that the patient has basically, if we see CDB say the patient should have at least 7 days of opioid free period before starting of the naltrexone. So the opioid free period for opioid and for alcohol are different. So for alcohol, it should be 5 to 7 days, and for alcohol it should be 5 to 7 days, whereas for opioid it should be around 7 to 9 days. So we have to see that there's a good there's 7 days gap between starting of this drug, and if we are still questioning is there, then we can use naloxone challenge for the same. So adverse reaction, one of the most important risks with the class of agent is that is the risk of precipitated withdrawals in those who have received high dose of opioid for therapeutic purpose, or in those who use opioid recreationally. As a result, patient should be abstinent from long-acting narcotic for at least 5 to 7 days. So this is the difference between naltrexone and naloxone. So drug, both are opioid antagonists. Naltrexone can be given orally, whereas naloxone is available in IV, IM route, and intranasally. The formulation where we give is naltrexone Vivitrol, where There are like different formulation for naloxone, like semi narconon. Then route of administration, then onset of action is 1 hour to 2 hours, whereas naloxone has a much faster action, 2 minutes to 5 minutes. And the duration is like 24 hours to 72 hours for naltrexone, whereas the duration of naloxone is 30 to 90 minutes. Whereas the main difference is like the use, whereas naloxone it works as an antidote for opioid overdose, whereas naltrexone opioid use it can be used in opioid use disorder and alcohol use disorder. These are my references. Second.
clearly mentioned that the naloxone program. What is it? Without very obvious answer. Right? See, what is the difference between detoxification and toxicity? Naloxone is toxicity, not detoxification. नशे में है तो थोड़ा ना लोगों ने तो बताओ क्या समझाई करोगे कि very important must know is a light saving although it's a video message but not as I mentioned doesn't be there or even they know about it you need to see enforcement managing बिल्कुल absolutely पता होना चाहिए कोई डॉक्टर तो हमने लोगों को देना है दोनों से लाइट अगर हम लोग पिन पे तो मेरी मर्दा इंडिकेशन सब में रिपोर्ट पिन का पूछा था तब तो मैं बहुत खराब कर देगा but anyway for others definitely and ये तो ऐसे तो बड़ा चीज पर ठीक है नहीं है और मिल नहीं है हाइपरवेंटिलेशन में होगा इसके सारे का साइनोसिस होगा सारे साइनों के लिए तो लॉर्ड इज द ऑपरेटेड तो दिस साइन ऑफ टॉक्सिसिटी इमीडिएटली देन ऑल्सो तो लगा दे एक दिन मैं मत से डाल दे ठीक है तो अगर साइनो थेरेपी इंटरेस्ट इसमें ऑपरेटेड तो लोगों को देना है ठीक है उसको तो यू मस्ट बी टेन अबाउट डिफरेंट टॉक्सिसिटी एंड डिटॉक्सिसिटी and pinpoint people बहुत बड़ा हेल्प करता है ये डिफरेंट कहते हैं कि मतलब ऑपरेट टॉक्सिसिटी का या कुछ हो जाए एक एक बहुत आपको कुछ कर देगा then also opioid toxicity particular dilated टॉक्सिक only but ज्यादा टाइम हो गया सेरेब्रल हाइपोक्सिया हो गया सेरेब्रल हाइपोक्सिया में डायलिसिस बनेगा so it will be careful but still you should be good enough to diagnose opioid toxicity as per depression sign is your good opioid ठीक है तो नैलोक्स है ना और अगर आपने इंटॉक्सिकेशन कर दिया तो आप 0% आपको उसका एनेस्थीसिया देना होगा बाकी सारे खा सकते हैं जो भी आपका मतलब फॉर्म आता है hyperventilation, polyalcohol level, pinpoint pupils,
Respiratory depression, unconsciousness, waves, post unconsciousness. IV, ISC. IM 0.4. Moxley में है this like वो दिखाओ तुमने Moxley में there is a point chart of that 0.2 after 5 minutes and then 40 like every 30 minutes you have to repeat also think we showed that chart. The chart. And we should do the 0.4 to 0.2 mg. हाँ मैंने लिखा भी है. I have given a written letter. I have approved, given letter that is life-saving drug. We need this for naloxone. और एक और drug था कि that we need this because we are treating opioid patient. So हाँ how? मजदूर भी नहीं है आप. मजदूर भी नहीं है. हाँ मजदूर लो. अच्छा. And yes, we get mild to moderate withdrawal वाले पेशेंट मिलते हैं. हम लोगों को ऐसे मिलते भी नहीं है. दूसरा ये है कि like of course it should be there in medicine emergency. और देखे हैं पेशेंट ओपियोइड टॉक्सिसिटी के केसेस देखे हैं हमने यहाँ. मैंने यहाँ पे देखा है एक पेशेंट डॉक्टर पांडे के अंडर में आईसीयू में रहा था काफी तक फैसिलिटी के साथ में. सीजर भी आ गए थे उसको. तो वो कुछ नहीं कर सकते, वो इंट्यूबेट कर देते हैं. इंट्यूबेट करके एंड देन वेंटिलेटर पे डाल देते हैं एंड देन वेंटिलेट. अगर नैलोक्सोन होगा तो जल्दी आ जाएगा और रिवाइवल करते हैं. हाँ आप you have to repeat. मैंने तुम लोगों को पहले ही बताया. मतलब इसमें अगर if you have access to Netflix, there's a documentary heroin उसमें of a unit in US where the paramedics are trained because the overdose is so much. Okay, and they just given well it is an emergency situation. Somebody is not breathing. So वो तो जहाँ पे एक्सेस मिलता है जीन्स के थ्रू वो ऐसे स्टैप कर देते हैं. जहाँ पे उनको मिलता है they just give an iron injection so that the patient, and within 2 minutes the patient start breathing. And the person herself is saying that they are not very happy with it because we have revived them, they are living, but then they have to go back and get there again and get the shot again. So many times they are not happy that we have revived them. So what you say about intoxication में तो नहीं है required अगर वो breathe कर रहा है तो it is not indicated. It is not indicated. It is just a life-saving drug. If the patient is having respiratory depression and if you do not go then hypoxic encephalopathy उसकी तुम समझो हाफ लाइफ कम है उसकी. दूसरा हो गया जो चैलेंज टेस्ट. सबक्यूटेनियस में तो क्या धीरे धीरे आएगा. आईवी में 0.2 देते हैं और उसका फिर 0.6
But we used to do, I'm teaching that also. हम पॉइंट आईवी में जो हमारे पास एंटी आता है वो 0.4 का आता है. तो बट वी डू इज इंजेक्ट 1/4 of the ampoule, that is 0.25 ml, and keep the syringe inside the vein when we give IV, and then wait for 30 seconds. 30 seconds में withdrawal आने लग जाएगा उसको. syringe स्टार्ट हो जाएगी, डेग्राइवेशन स्टार्ट हो जाएगी. Then अगर हो तो हम syringe वापस निकाल लेते हैं. अगर नहीं होता तो withdrawal तो हम पूरा इंजेक्ट करते हैं. फिर then we see it. तो आपका थोड़ा डिफरेंट है जवाब.
30 seconds we 0.2 naloxone 30 seconds 6 वो जो होता है ना 4 mcg per ml है शायद 2 ml उसमें होगा पूरे एम्पूल में 8 mcg. आई डोंट नो नैलरेट के नाम से आता है. तो देर या तो तुम 2 एम्पूल लो एक बार में. हाँ 0.4 से तो हो जाता है. मतलब दैट इज जस्ट टू चेक दैट इफ ही इज नॉट हैविंग वो 0.4 से इट इज सफिशिएंट. आईवी अगर दे दिया दैट इज. अदर वन इज दैट यू कैन वो मेजर करना मुश्किल होता है तो इन एनएस और समथिंग यू कैन डाइल्यूट इट कि पूरा उसको 5 ml या कर लो, 2.5 ml दे दो, रोक लो, या 1 ml दे दो, रोक लो, फिर स्लो. The dose, more than dose, it is like you give only little amount, and if it does not precipitate a withdrawal, we keep on giving the whole injection. That's the only thing. Over a slow bolus time, over a period of 2 minutes, you can give. And if he is okay, then you can go ahead with naltrexone. So I gave there for this also, and for risperidone long acting. Risperidone long acting also patient है 1,000 rupees का इंजेक्शन है, वो 6,000 का है. तो रिस्पेरिडोन तो उन्होंने कहा अप्रूव कर दिया था, हाँ कर देंगे यार. ये इसके लिए वो वेंडर ढूंढ, कह रहे सर आपको वेंडर का नाम मालूम. मैंने कहा मैं कहाँ से वेंडर ढूंढूं, naloxone का वेंडर नहीं पता है कोई. तो जो है इट्स सॉर्ट ऑफ एन ऑर्फन ड्रग है. तो अगर वेंडर कहीं से मिलेगा तो हम उसका रिस्पेरिडोन के महीने में मेरे को वेंडर नहीं पता, बस यहाँ आता था. आई डोंट नो, बट इट इज लाइक 6 times the cost of this thing. Many patients, they were doing okay on risperidone long acting. So now we have to shift them. Anyway, so naloxone, you are saying, is naloxone orally effective?
Yes.
It is, but you have to give in very high dose. बहुत हाई डोज में उसमें है लिखा 3,000 जैसे कुछ देते तब जाकर भी आता है. ऐसा नहीं बिल्कुल ही एब्जॉर्ब नहीं होता. मतलब कि अगर कोई 10, 12, 15 खा लेगा तो होगा. दूसरा जो है comment from others. तो आपने हाँ बताओ, if a person misses one naltrexone and then
But the half-life of the drug is still
what
72
will happen
hours.
if we take, the basic question is what will happen if we take
10 hours. म्हणजे 10 hours होतो. Then
72 hours.
also. क्या difference है? Plus patient है 10 hours में. So 10.5.
You're right, and in one place it is 72 hours. Right. Yeah. Blockade lasts for
But this is the blockage and the plasma half-life are both different.
That is around 90 hours. Okay, so 72 hours. And in lot of cases, they give it 5 days. Probably 100 milligram doses. So
5 half-lives. 5 half-lives लगता है ना, तो 50 hours लगा लो, फिर 50 hours रहेगा ही वो 5 half-lives.
most likely case में
Meaning, what is not happening? Like, what is not happening? What do you expect if a person takes naltrexone के ऊपर में he take? Right.
So as to achieve that high, and then
Yes. Okay. That's what happens. That's what can happen. And it is also what at what time is like is used for one day. Okay. फिर वही है उसकी हाथ, वो तो नैल्ट्रेक्सन तो कम होती चली जाएगी ना फिर टाइम. अब नहीं लेता है वो नैल्ट्रेक्सन, फिर तो वो हो ही जाएगा, उसको इंटॉक्सिकेशन भी होगा, उसको ओवरडोज भी हो सकता है. कौन सा प्रिपरेशन किया उसने, ठीक है.
Then after 80, 90 hours to do. That's why they use that's why it is effective.
हाफ लाइफ क्या होती है? एलिमिनेट। ठीक है, तो हाफ सौ भी बचा है ना, तो कुछ तो काम करेगा वो। हाँ, तो निकल जाए। ठीक है। देखो उसने स्टार्ट करने के लिए लिखा है पीछे, हाउ डू यू स्टार्ट? Lower dose can be considered over the first few days of the patient as increased adverse event. कितने कितने टाइम पे देना चाहिए? 7 to 9 days देना चाहिए। लोग देते भी जल्दी है। हम लोग देखो, इट इज ऑल प्रैक्टिकल। हम लोग ये प्रैक्टिकल एक्सपीरियंस है कि आर पेशेंट्स आर नॉट अब्यूजिंग दैट। ओके, otherwise you have to wait for 7 to 9 days before you give naltrexone. Here we see clinically that they are not having any withdrawals. 4 5 days they are not having. So that is why we start with a much lower dose. 25 या 25 का भी हाफ देते हैं हम लोग, है ना, for over a few days. Why? naloxone होगा तो हमारे लिए काम इजी हो जाएगा। naloxone टेस्ट करके तो हम 25 50 दे ही सकते हैं। ठीक है, उसमें एफडीए में है कि इनिशियल डोज 25 का वहां पे भी देते हैं सर, 9 days के बाद में। ओके, एंड इफ देयर आर नो विड्रॉल सिम्टम्स देन यू गिव। ठीक है, यहाँ पे हम लोग जल्दी दे देते हैं, 5 7 days में, 6 7 days में देते हैं, 6 तक नहीं देते हम लोग ज्यादातर, है ना। और इसीलिए लोअर डोज यू कैन स्टार्ट की यू डोंट वांट टू प्रेसिपिटेट अ विड्रॉल। कुछ पेशेंट का फिर भी वो भी आता है, वो बोलते ही हम लोग बोलते हैं कुछ नहीं हुआ, बट ठीक है। ये भी आस्था ये सी, ये naltrexone का हम लोग वो कर देते हैं। We have put in a lot of patients, but the implant, but we have discontinued because the rates of like success rates are okay. Not available. हाँ, पर उसके ऊपर भी है कि वो फीमेल थी एडोलेसेंट, उसको दिया था, लाइक शी वाज इंटॉक्सिकेटेड यूजिंग इट ओवर द इंजेक्टेबल आल्सो, क्योंकि वो मसल से कितना होता है एब्जॉर्ब नहीं होता है। तो बुप्रेनोर्फिन देने की कितनी देर बाद है, पीछे देखा था उसके 5 to 7 days ही है वैसे।
Definitely is like a partial, it has a mixed, so pure organist थे तो टाइम कम कर सकते हैं सर।
टाइम कम कर सकते हैं, ठीक है, ओके। और ट्रामाडोल के बाद कितनी देर बाद दे सकते हैं? तो these two question remain और the PGs task। बुप्रेनोर्फिन कितने दिन बाद? वेरी गुड, yes, so the in the dose depends and the duration। 8 mg से ऊपर तो 8 mg है, कितना देर वेट करोगे, और 2 mg तो कितना करोगे? मॉड्सले में दिया हुआ मेरे ख्याल से। It depends upon the dose and the frequency and individual variation है, but 2 mg लाइक हम लोग को ज्यादा 2 mg वाले मिलते हैं, तो उसमें 48 आवर्स के बाद we can get 72 आवर्स को। हाँ, हाँ, अगर इमिडिएटली दोगे तो आ ही जाए 72 आवर्स के बाद। हाँ, हाँ, ये भी है, कुछ लोग 2 mg लेते रहते हैं, उनको 2 mg में भी दूसरे किसी अच्छा खासा विड्रॉल आया था, जबकि राइनोरिया, लैक्रिमेशन, पेन वेन, शायद वो भी होगा कि कितनी दिनों से ले रहा है।
Side effects of naltrexone, I think mental health. काफी गुस्सा नहीं है, क्या है, कोई काम आता हो।
Psychiatric तो सर इन CTPI स्टडी तो थेरेपेटिक इंडिकेशंस तो ये थे सर.
Adverse,
Dysphoria is there, sir. Dysphoria. So dysphoria was more with naloxone. So it was introduced. Naltrexone was introduced. Though some dysphoria is still there, but it's better than in naltrexone.
yes, you still using it. More, more than he case of he used the tablet, but he injected and even then he was getting a diaspora also is a big that no can. Yeah. Hello. I think their patients will already have it. Hey, just before we go, Rupali, I told Dr. Mehta and Dr. Mehta, we are uh, uh, making units. Okay, because we've been asked by the MS and the principal for an NC purpose because seat allocation is accordingly. So unit 1, unit 2, unit 1 me, Dr. Mehta and Dr. Sanjeevi, unit 2 is you, Dr. Khatri and Dr. Okay, Shobit. Dr. Shobit is in charge of unit 2. So, and OPD days are just as we said. Okay, just for the administrative purpose, we will be having those. So you are Simran is in unit 2. Yes, and Aditi is in unit. Okay. The residents will work frequent, like working will remain the same. So you can still see patients of unit 1 in the round. It's not like that, that you can see doctor like my patients or doctor patient as it is, but we for the uh, we'll see if they want something more. अभी तो यही किया है, उसके बाद देखते हैं अगर वो बोलते हैं बेड सेपरेट करना है जीआर या जो भी है तो फिर वी फाइन. करंटली यू आर यूनिट 2 विद यूनिट 1. ठीक है, रेस्ट एवरीथिंग इज सेम. ठीक है.
जी. इसको बंद करके